Hey everyone, and welcome to this explainer where we're going to unpack the massive 2025 EULAR guidelines. And let me tell you right up front, what changed in 2025 is not just some minor tweak to the old rules. It is a fundamental, absolute shift in how we think about kidney involvement in systemic lupus erythematosus. The update quietly but very firmly moves us away from a reactive, treat the flare mindset and pushes us toward a proactive, protect the kidney long-term strategy. As we dive into this, you're going to see how pretty much every single recommendation follows that exact logic. So, we've got a really clear roadmap for today. We'll start with the paradigm shift, then look at upfront combination therapies, rethink our steroids and targets, explore the upgraded non-immune therapies, and finally, talk about playing the long game. Let's get right into it.
Starting off with our first pillar, how we are fundamentally redefining this disease. So back in 2019, the terminology was simply lupus nephritis. But for 2025, it's been deliberately changed to kidney involvement in SLE. Now, I know that sounds like just a Semitic wording tweak, right? But clinically, it's a huge philosophical change. Kidney disease is no longer being treated as this separate, isolated silo. It's a fully integrated part of systemic lupus care. It forces earlier, broader thinking beyond just looking at proteinuria alone, and it heavily reinforces things like the need for overall systemic management, like ensuring hydroxychloroquine for all patients. And honestly, if you literally only remember one thing from this entire explainer, make it this. Lupus nephritis is not just an inflammatory disease, it is a chronic kidney disease in evolution. The goal is no longer just putting out the acute fire of inflammation, it is all about continuously protecting the functional reserve of the kidney to prevent long-term nephron loss. That is the core thesis driving everything we're about to talk about. Okay, moving right along to our second pillar, and honestly the biggest headline change of the whole update, upfront combination therapy. We used to have a pretty standard playbook. Under the 2019 approach, the default was starting with single-agent induction therapy, right? You'd use MMF or cyclophosphamide, and you'd kind of hold biologics in reserve, just in case. Well, the 2025 update flips that entirely on its head. Combination therapy is now recommended up front for most patients. The field has finally moved beyond just crossing our fingers and hoping the kidneys respond to a single agent. The new strategy is to hit early and hit smarter, and this is heavily backed by recent phase 3 RCTs that show clear superiority over standard care. So, single-agent therapy? That's now framed as a selective fallback, not the standard. Instead, we have 3 preferred upfront combinations taking center stage, especially for patients who have poor prognostic factors. You can combine your base therapy with belimumab, which is well-established and has a great safety profile. Or you can add a calcineurin inhibitor, like voclosporin or tacrolimus, which is amazing for rapid proteinuria reduction. Or you can go with a completely new addition, obinutuzumab. And I really want to highlight that last one. This is a quiet but absolutely major endorsement of B-cell targeting. Previously, anti-CD20 therapies were generally viewed as a rescue therapy, right? Just for those really stubborn, refractory cases. But now the 2025 update explicitly positions obinutuzumab as an early, core strategy because it induces a much more consistent and deeper depletion of B cells. It gives clinicians a seriously powerful tool right out of the gate. That brings us to section 3. Let's look at how the guidelines are rethinking steroids and setting up some hard, actionable targets. Now, there isn't a revolution in the drugs themselves here, but there is a massive shift in philosophy when it comes to steroids. We all know they're necessary, but they're increasingly viewed as a toxic liability that we absolutely must minimize. So after your mandatory early IV pulses, the tone is crystal clear. You want an aggressive taper down to 5 milligrams or less per day by 4 to 6 months. And the ultimate aim? Complete withdrawal wherever it's actually possible. Keep them on a very tight leash. And to help us get there, the update throws out interpretive ambiguity and gives us these incredibly clean, actionable thresholds. By 3 months, you are looking for at least a 25% reduction in proteinuria. By 6 months, you want a 50% reduction. And at the 12-month mark, the target is fixed, not a range, a fixed target, a urine protein creatinine ratio of less than 700 milligrams per gram. This simplification is fantastic. If your patient isn't hitting these exact milestones, it's a glaring signal that you need to reevaluate their regimen. Let's pivot over to section 4, where non-immune therapies get a massive upgrade. We are officially tossing the word adjunct out the window. The guideline now defines non-immune therapy as a co-equal partner to immunosuppression. This is a huge realization that long-term outcomes are driven just as much by hemodynamics and kidney fibrosis as they are by immune activity. So we're seeing a really strong emphasis on continuous ROS blockade, cardiovascular and bone protection, and the brand new introduction of SGLT2 inhibitors to reduce kidney workload and delay the decline of the glomerular filtration rate. When you put it all together, you get this incredibly comprehensive, holistic approach. You have precise diagnosis, early aggressive immune treatment with those combination therapies, dedicated non-immune kidney protection, and a highly nuanced approach if the disease is refractory. Speaking of refractory cases, the update actually promotes switching across mechanisms rather than just linearly escalating doses. And it even gives a forward-looking nod to experimental treatments like CAR T-cell therapy. It's a true two-arm model now.
Of course, it's one thing to have guidelines and another to actually practice them. To close that gap, EULAR introduced 3 measurable care indicators. Are you using combination therapy? Are you meeting minimum treatment durations? And are you prescribing non-immune kidney protection? But what's really great is that they also embrace clinical realism. They avoid rigid algorithms. They don't force strict separation of class 3 or 4 versus class 5 in treatment choices. They are leaving room for and ultimately trusting your clinical judgment. Finally, we arrive at Section 5, playing the long game, which focuses on treatment duration and the role of biopsies. This is such a critical insight. The guidelines explicitly acknowledge the tricky gap between what the lab results say and what is actually happening deep in the tissue. Clinical remission simply does not always equal histological remission. Your patient's blood and urine labs might look amazing, and it's so tempting to pull back on the meds, right? But the hard-earned lesson here is that stopping therapy too early costs nephrons, because every single flare causes irreversible damage. So the new rule of thumb? Stay the course. The guidance mandates continuing therapy for at least 3 years after a clinical response. And a lot of experts are leaning heavily toward treating for around 5 years before even considering withdrawal. And how do you know it's truly safe to stop? Well, the repeat kidney biopsy is getting a much stronger, more strategic role. You use it to check the actual tissue for lingering microscopic inflammation before withdrawing therapy, ensuring you don't trigger a devastating relapse.
As we wrap up this explainer, I want to leave you with this final thought to challenge how you approach your very next patient. The 2025 EULAR update has handed us an incredible toolkit: upfront combination therapies, strict steroid limits, and co-equal non-immune protections. But the true paradigm shift, the one that really matters, has to happen in our own mindset. So ask yourself, are you just putting out the fire of today's flare, or are you actively protecting the kidney's long-term future? Thanks so much for joining me, and keep learning out there.